Ajoy to speak on refractive lens exchange.
I think we needed two more subjects to be finished before I would have touched that. But then Dr. Sonu is still not here because he's gone for his lunch, and then he is to do the lenticle base and the phakic IOL. And that's why this is the last option. This is not basically refractive, but if you are a refractive surgeon, you have to have this also. I mean, patients of all age would come that I want spectacle-free life. It could be somebody from 10, 12, 15. Well, definitely the consensus is that you do it after 18 or 19 or when the refraction has stabilized. But it could be as late as 45, 50, 55 that they would still want to be. And this is the option where you would now. How does it differ from a normal cataract surgery? Now I would be talking about it. Yeah, so I'll be speaking on this. Well, what are my choices for my criteria for choosing a patient for RLE? Well, definitely the refractive status, patient's age, the corneal thickness, and the lenticular abnormalities, if at all that is present. I'll be just showing a femto cataract removal or femto lens removal in the background. So for me, the LASIK, as I said, LASIK or advanced PRK option is anybody between 18 to 50 years, 0 to 8 diopter of myopia. This is the broad heading, no corneal or lenticular abnormalities as far as the thickness of the residual bed thickness is there. There's no contraindication, or there is adequate corneal thickness. Now, these are definitely my first choice for guiding the patient to undergo LASIK. Or for me, the phakic IOL is any myop over the age of, this is where I would advise, or above 5 diopter of myopia with thinner corneas. And if above 8 diopter, if you have thicker cornea, definitely LASIK would be my first choice. And the age would definitely also be a factor. But when it comes to refractive lens exchange, any myop over the age of 50 years with inadequate corneal thickness. Now remember, inadequate corneal thickness for any corneal-based procedure, if the patient is there or if the person is there for, again this, and any hyperope of, this is the hyper of any age above 4 diopter, and especially those who are above 45-year-old. Now again, I would again avoid, even for hypermetropics, doing at a younger age, or younger age anisometropes, which cannot be corrected. I mean, below 50 or below 45 would be my choice, or shallow AC in high hypermetropia, where even a phakic lens or anything that I would like to give, that is not possible. So that is one of the options that I have. Well, so you have a limited choice, and definitely presence of water vacuoles in the crystalline lens above the age of 40. Now that is where I would not go for a phakic IOL. Talking about is the instability of capsular bag. That's a problem. The increased risk of PCR in the myopes. There is a increase of the intraoperative or subchoroidal hemorrhage. There is always a risk. And capsular block syndrome. Now this is the intraoperative risk that you have. To remember that in a hyperopic, definitely a shallow entry because you're cramped up for a small space. Choroidal effusion, the malignant glaucoma can be at some time. So before taking this procedure, counsel the patient that you could, it's not easy go and just go. And the incidence of RD as high as 10%. Now this is something you should remember. I mean, the reason why RLE was not accepted, all this widely accepted as a form of refractive and is the risk of RLE. But today with this higher machines and machines which you have a control of the internal milieu, whether the anterior chamber, the fluctuations, you can keep it down. Definitely it's one of your choice in armamentarium, but to definitely lower the risk of CME or lower the risk of RD, if you have a total control of the surgery, we'll come to that. So increased risk of RDs with the younger age, male patients, any axial length more than 27 millimeter, presence of PCR and having a YAG capsule to be done immediately after surgery. So again, PCR is something, I mean, you can never predict, but I think you're still having that problem, huh? Even video pen drive, I think we put it in this system. I think it's in the, so capsular exit. Let's come to the surgery proper. This is a high myopic patient where the axial length is around 28.5 and we are putting around -3 diopter of lens. Now look at this patient. So this is a high myop patient. Now very important that you have that capsular rhexis right in the center. Remember, this is a clear lens. Rhexis should be as central as possible, as the round around 5 to 5.5 millimeter. 5 millimeter is what I would suggest, because if you look at, this is a hypermetropic eye where 21 diopter axial length, we are planning to do 21 diopter with the 29 diopter lens. Now, rhexis marker is something you can be handy if you are not having femto in your setup. So you have the right, now this is very important, that why you should have specifically for RLEs, the right rhexis, the right central, because any shift of the lens over a period of time would invite early PCO, and then you have to do YAG, and then the risk of retinal detachment. So if you can prolong the YAG capsulotomy or the PCOs in early stage as late as possible, because this some with the advanced technology lenses, the chances of PCOs are less. And again, nucleus removal. Now this is a deep anterior chamber. You have to be proficient enough. The machine should be such that you can remove the lens with minimal of damage. I mean, the techniques that you would do for a high myope, it could be chip and flip or a cartwheel technique, as I've seen, but then always keep the anterior chamber intact. Never let the anterior chamber go down, because that fluctuation is the one which would induce PVD and chance of retinal detachment. Here we're doing a hypermetropic eye, as you can see that one. This is a around 52-year-old gentleman, has early lentil sclerosis, as you can see. I'm trying to do it IOP30, and I've fixed the this vacuum around 600, but still I'm feeling some, fluctuation. The anterior chamber is too, tight, so I've increased the IOP to 30 to 40, and that's where I'm getting a better control. As you can see, this lens with the aspiration rate of 20, if you can get the hold of it, as you will know that it needs a bit of learning stage to, learning curve is there while we are using this Centurion machine with this IOP control. But then if you can get a good hold and good control, definitely and see the minimal fluctuation that I am trying to, though hypermetropic, it may not matter, but in myopes it's very important. The fluctuation in the anterior chamber should be kept as minimal as possible. Once you remove that, and the choice of bimanual irrigation and aspiration. Now this is what, again, do a good capsular polishing, remove it bimanual, where at no point you are losing your anterior chamber. As you can see, orange or a peel method, go from the periphery, come to the center, and do a good capsular polish. If you have got a IA system where you have got those serrated tips, and biometry is again so important in these cases. I think it's gone blank again. No, there's no signal. Cable. इस साइड का केबल खराब है तुम्हारी। So advanced technology IOLs, the biometry, as I said, I think we have the little bit not discussed in detail here, but definitely a Barrett's formula is something we do. SRKT is something which I do it for my normal cases, but Barrett's universal with the IOL Master 700 and the keratometer with the best possible, the IOL Master 700 does. Along with that, a manual keratometry is also added, or use the pentacam. Now, when you are doing infusion lead, but because this is high myopic, lens might oval a bit, but see that your lens is directly central, well placed, and there is a margin of anterior axis. Now, since being a high myopic, as you can see, in spite of having almost 5 millimeter axis, you can see it seems that the lens is covered, but remember this lens would come forward over in the post-operative period, immediately after post-operative. So this coverage would be enough, or the anterior shrink effect would be enough. In case of well formed, now femto laser is one of the options that you have, because here you can actually have a well round central capsular axis, and if you have a variant in your disposal or any of the marking systems which are there, that would, perfect, because these are the patients at the age of 50 or 55 would want to be rid of glasses. You are putting an advanced technology lens, so if you have in your disposal, and as you can see the soft cataract, you can just dissect it, and most of the time you struggle with the soft cataract in most of the machines, but with the visco dissection, with the 6 cut, it becomes easier to remove those soft cataracts, which would be, most of the time you'd struggle to get a hold with your machine, but then those small, and then the marker system, as you can see, in this case we'd be putting I think it was a Symphony toric lens. As you can see, the marking, the manual marking is so commensurating with the marking of the variant. I think it's 105 degree, and that almost tallies with the manual marking that you have. So you have a double check in both the manual and the variant system that's there. And putting the lens right, yes, this is again in a multifocal lens. You have that variant marker where you have got a central 2-3 circles which should tally, or the central part, the reflex that you see should be in the central part, and that would give you a better control. As you are placing this lens, you can rotate it under infusion. At no point have I allowed the anterior chamber to become shallow or lose the anterior chamber, or lose the fluctuation in the anterior chamber. There I just placed that lens. This is a Symphony toric lens, just tallying with the, so one has to be perfect in these patients, demanding patients who would be definitely ready to pay you, but then at the same time would want a perfect result. So that if you look at the studies in support of that, there's almost 100% improvement of uncorrected visual evidence, 75% of improvement in best corrective visual vision. And this is the myopic study. Myopic RLE study says the RLE was predictable up to 87.5%, and within 1 diopter, and 95% within 2 diopter. In hyperops, surprisingly, you would find a lesser prediction, 88% in low hyperops within 1 diopter in the target, and 58% within 1 diopter because the hyperop biometry, I suppose, is not to the mark, and many a times hyperops are not that happy, because if you have a vision with the plus 12 lens that is seeing 6.6, many a times with the lens, you would, because of the hyperops have a magnified image. Once you put in a lens, the size or the size increase, but the patient is used to that. So what would be around 618 or 612? The myops, the opposite happen. Even if they have pre-operative around 612 or 612 partial and all, it definitely increases up to 6.6 or 6.5 if you have because of the minification effect that they had with that myopic lens, and we put in a lens that the satisfaction level is definitely higher with the minor. So in conclusion, it's not for every patient. Considering refractive surgery, you have got a steep subset of patient. It's elective intraocular surgery that needs to be minimally invasive, performed with precision and high accuracy. That's what I said, that if you have enough of experience removing your cataract, removing your over a period of time, you have got enough of experience that on your machine that you can perform, and you have the least PCO rate. I mean, it's very difficult to say what my PCR rate, but especially in high hypermetropia or high cataract with high myopia or cataract with high hypermetropia, once you have done that, definitely these are the patients that you would counsel to get under refractive lens exchange with the presence of refractive error in the absence of cataract. Now that's a tough, but with the risk-benefit ratio in mind, depending on the age or refractive condition or preoperative condition, proper counseling, definitely the main challenge involved would be to reach emmetropia. But with those modern machines and modern lenses, with the rapid recovery, with astigmatically neutral incisions, this can be done with greater predictability today than it was done, say, 10 years back. So today, definitely, it can be one of your armamentarium in your refractive surgery. Thank you for your patient here.
Thank you, Dr. Ajoy Pal. Yes, I am sure with the improvement in the quality of surgeries and the predictability of the outcome, this is again resurging back. But we still have to be very, very cautious in our patient selection. Any of us who have any queries on refractive lens exchange? Before we go on to the last topic of today's session? So, no, you can.
So in refractive lens exchange, we are mostly talking about axial lens which are more than 26 and 27. So do you think the Van-Cock adjustment has a, do you use that in your biometry to calculate the IOL power, or it's only?
Right now I am using universal to Barrett universal 2. It's there in my IOL Master 700. So I mean, we have been having it for quite some time now. So that gives me the best result. And I'm anyway in high myopes, whatever I always target for, because it's very important that you target not emmetropia, a bit myopic, so that because most of these patients you would not like that anywhere you go wrong with the best of technology that we have, even that Wang, the modification that you, in spite of that, there have been reports that you do have. So for myopes, anyway, I would for these high myopes aim around -1, so that patients are quite happy with that, for the range of near vision that they have.
And for a second question, for a younger patient, say like around who's maybe 30, 40 years old, you would prefer a symphony or you would like to go for a trifocal?
Yeah, see,
Or maybe a symphony
over
or
a period of time, I've realized myopes, they do better with a symphony lens. Any high myop and because of the refractive, because myopes are used to a wide range of vision. A hypermetrop is a very specific, a little bit here and there. So trifocal would be what I would prefer for a hypermetrop, but for a myop, definitely a symphony or symphony toric as.
Thank you.
I think, but very rightly you said that accurate biometry is what is very important when you're using either a symphony or a trifocal lenses.
Yeah, we need to actually do two things. One is use at least two or more type of formula to find out that the biometry is more accurate and the lens power is similar. And the second is both eyes has to be done together.
So for people who have not been using ICLs, so let's have something to begin with.